Welcome everyone. So let's talk about a very common condition in the emergency department. It is vertigo. Vertigo is the illusion or just a false feeling of rotatory movement when there is actually none. It should be differentiated from dizziness, which have a multitude of meanings and causes. Vertigo usually is caused by dysfunction of vestibular system. It's important to try to differentiate between the two types of vertigo, which are peripheral from the central one. Generally, peripheral vertigo can be managed as an outpatient, while patients with the central vertigo should be admitted and needing more investigations and management, especially MRI. So what are the features of peripheral and central? It might be difficult for many people to differentiate, but there are some points that can make you to reach the diagnosis. Both of them can be sudden, but peripheral may be more sudden. In central one, it is gradual or very sudden, like in stroke and TIA. But if there is a space-occupying lesion or tumor, it can be gradual. The duration is less than 48 hours, resolve usually less than 48 hours, but there are some conditions which may prolong. But central one usually persists, except the TIA, which is for a short time. Nausea, vomiting is more severe in peripheral, mild in central one. There might be auditory symptoms which accompany the peripheral one. Example, oral fullness, feeling of tinnitus, and hearing loss. The triggers, often exacerbated by mild head movement and positional change, may exacerbate the condition in peripheral, while in central, little effect is from head movement. Neurological symptoms, if there is neurological symptom, it implies the central one. Example, dysarthria, diplopia, dysphagia, dysdiadochokinesia, and also dysmetria and hemiparesis. I mean, when the patient is feeling numb and weakness on one side. Past medical history of atrial fibrillation, hypertension, cardiac disease, previous stroke may imply more the central one, while previous history of paroxysmal positional vertigo or recent ear infection can imply a peripheral cause. The causes of the peripheral one are many. Most commonly is BPPV, the benign paroxysmal positional vertigo. It might be Meniere's disease, vestibular neuronitis, acute labyrinthitis, otitis media, cholesteatoma. Each one have its specific feature. We will talk about it. And the central one, stroke, especially the stroke of the cerebellum. TIA of the cerebellum, acoustic neuroma, which is a tumor. It is hard to detect it. Cerebellopontine tumors as well. So what investigations do you do? Mostly, the most useful investigation in suspected central vertigo is a CT to exclude hemorrhage, but MRI is more important because MRI can show cerebellum and posterior stroke easily or better than the CT. Other investigations aimed at looking for the risk factors. For example, doing an ECG, postural blood pressure measurement, echocardiography. This is more going with the dizziness. The peripheral vertigo requires very little investigation. Usually, it may need just an EN test and audiological testing and some simple maneuvers. For whether it is a central or a peripheral vertigo, mostly this is going with the peripheral one. You have some symptomatic treatment. You can suppress the vestibular system by giving diazepam or lorazepam tabs. You can give antihistamine or with anticholinergic property. Example, cinnarizine. Cinnarizine, also call it Stugiron. The dose is 25 it's usual 25 milligram 3 times daily. Cyclizine can also be used. Antiemetic, especially prochlorperazine, which is called Stemitil. Stemitil is an ampoule that is 10 milligram. Here usually IM1 is available. It's very useful for vertigo plus vomiting. If not available, metoclopramide, which is Placil, is also a good choice. IV fluids, especially if the patient have repeated vomiting. So these are symptomatic treatment. We usually use a Stemitil ampoule and the Stugiron, and also sometimes you use another drug called beta-histine. This is also very commonly used, beta-histine. The beta-histine is an antihistamine. The tab is 8 to 16 milligram, can be used 3 times daily. Many people combine beta-histine plus Stugiron and give Stemitil while they are vomiting. Also, if you suspect vestibular neuronitis, sometimes people tend to give steroids, especially we give dexamethasone. So we give a dose of 8 milligram and patient will be having improving symptoms. Coming to the most common one, benign paroxysmal positional vertigo, there is debris otoconia, usually calcium debris collect in the semicircular canals of the ear. This can cause vertigo on minimal head movement. It's most commonly associated in the over 60s age due to the formation of the calcium carbonate, but can even occur in younger age. This is common in younger age after head injury. Sudden changes in the position can result in short paroxysms of vertigo. Diagnosis is usually confirmed by Hall-Picke test. So this is for diagnosis. And this can be treated when the diagnosis is confirmed, can be treated by Epley's maneuver. So this is the only treatment. Does not need further treatment. You may give some symptomatic treatment like Stemitil, but usually the maneuvers would be best effective. So the maneuver is described here, but let us see the video, it's better.
Maneuver is used to treat posterior canal BPPV. To understand which side to turn the head to begin the Epley maneuver, one key piece of information is required. Which ear is the problem? To answer this question, the Dix-Hallpike maneuver is first performed. While sitting up, turn your head 45 degrees to one side. Then quickly lay down such that the head is tilted back 30 degrees. A pillow positioned behind the shoulders can help achieve the proper angle. Hold this position for 30 seconds. Sit back up. Now turn the head 45 degrees to the opposite side and lay down, again with the head tilted back 30 degrees. Hold this position for 30 seconds. If you have posterior canal BPPV, the eyeballs should twitch diagonally with a slight rotation that slowly disappears within 30 seconds. This eyeball twitching motion, known as nystagmus, will occur most severely on the side of the culprit ear. In this video example, the Dix-Hallpike maneuver triggered a significant nystagmus when the head was turned to the right side. As such, the Epley maneuver begins with a 45-degree head turned to the right. The body is then laid down with the head tilted back 30 degrees. Hold this position for 30 seconds or until the induced nystagmus and vertigo resolve. Next, turn the head 90 degrees such that the head is now turned 45 degrees to the left. The head is still tilted back 30 degrees. Hold this position for 30 seconds or until the nystagmus and vertigo resolve. Next, turn the entire body onto the left side. Because the head is still turned 45 degrees to the left, this results in the head facing down towards the floor. Keep the head tilted back 30 degrees. Again, hold this position for 30 seconds or until the induced nystagmus and vertigo resolve. Finally, sit back up with the head in a neutral position which completes the Epley maneuver. Let's repeat this.
Meniere disease, it is also known as endolymph hydropis. It is due to excessive endolymph production resulting in increased pressure in the semicircular canal. The patient feels oral fullness, tinnitus, and fluctuating hearing loss and peripheral vertigo. So the patients have these three symptoms: tinnitus, hearing loss, and peripheral vertigo. The treatment is symptomatic. Usually we advise the patients to have low salt diet, and sometimes they give acetazolamide or beta-histine. Sometimes surgery might be done. So this is much more going with the ENT problems. Vestibular neuronitis, inflammation of the vestibular nerve, thought to be secondary to a viral infection. So after a viral infection, if the patient feels vertigo and vomiting, usually the symptoms increase with head movement. So usually there is no disturbance in the hearing and no other neurological deficit. So this is the characteristic. Usually the treatment is symptomatic plus steroids. We have acute labyrinthitis. The labyrinth is associated with disturbance in the hearing, so there will be hearing loss plus vertigo. The patient might feel also ear pain, fever, and headache. So you have to send them for the ophthalmologist. Acoustic neuroma, also called vestibular schwannoma, it is usually a benign tumor of the myelin sheath surrounding the vestibular cochlear nerve. There is also involvement of the nerves that located in the cerebellopontine angle, which are cranial nerve trigeminal, abducens, and also the 8th cranial nerve. Unlike other central cause of vertigo, acoustic neuroma can result in gradual hearing loss and tinnitus. So the key point is that vertigo is the illusion of rotatory movement when there is none. It usually implies a dysfunction in the vestibular system. It can be peripheral or central vertigo. The emergency management focuses on identifying the cause and symptomatic relief of the vertigo, which are antihistamine and antiemetic and antihistamine. Further questioning should be done from the patient, asking about any neurological symptoms and risk of atherosclerosis to know whether there is a central cause or not for the problem. And thank you so much.